Hi, Dr. Smith.
Hello, Darryl. How are you doing?
I'm doing good. Hope you are too. Welcome to the conference. Thank you very much for being here. Can you tell us what kind of doctor you are and where you practice?
Absolutely. So I am a radiation oncologist based out of Brooke Army Medical Center in San Antonio, Texas.
And I'm guessing those are not surgical fatigues. You're a major in the Army, is that right?
Absolutely. Yes, sir.
Okay, so is it fair to say all of your practice your patients are military folks?
Yes. And for those who aren't familiar, so
Yeah,
not
go ahead.
necessarily the VA population in active duty hospitals. We take care of patients who are either active duty or part of the group that was in for 20 years or more and got retirement or got a full medical retirement.
Right.
And
But
their spouse's independence.
your practice is actually, I mean, you're in a hospital on an Army base, basically. Is that right?
Yes, exactly.
Yeah. So, I mean, before we get into the radiation therapy,
Yeah.
what do you see as, like, in 90 seconds or less, the primary differences or similarities between a hospital on a military base and one in the middle of town?
Absolutely. I mean, I would say, I think just to be frank, the number one differentiator is, when you talk about like a hospital in town, sometimes you can also take care of, all the way from very high income patients to you can be essentially like a county hospital where you can get all comers. So I will say here in the military hospital, I am a little bit spoiled in that all my patients are, 20-year retirees. So, on both the enlisted and officer side, they're both a lot of the times, higher achieving individuals. And some of them are more meticulous about their healthcare. So, I'll be one of the first people to admit that we have a little bit of a, I don't want to call it a more sophisticated population, but certainly, certainly they've, achieved certain things in the military as such. So I would say that kind of does contribute somewhat.
Yeah, and all your patients show up on time?
A lot more. And and in radiation therapy, sometimes we treat sites where people get some pain from treatments like in the head and neck, and a lot of the times the military patients are a lot more inclined to kind of tough it out without pain meds and things like that.
Yeah. Is there that sort of thing before I mean, this is actually sort of interesting, the idea of toughing it out. It's almost like, is the stereotype real as you see it?
A little bit, but it's by no means universal. I've had plenty of people when during my residency who were equally tough, if not more so. But yes, I do find, and certainly you already pointed out, one of the major things is, they're typically on time or, 15 minutes early, as is the tradition with military formations.
Yeah, and they don't have to pay for things, which is an added advantage, different from civilian population where paying for things is a stressor.
Absolutely. So that's one of the things is all care, received through the military healthcare system is free. I will also say we have a little bit more flexibility in terms of also sometimes doing treatments that may not be reimbursed by insurance. So, as a physician, as an oncologist, in the military, I feel both, more freedom, but I also, want to be, financially conscious of the burdens on the system. So, again, try to apply both, evidence-based healthcare and also, what do they say now? One of the pillars of, the Hippocratic Oath or something should be like, you're not going to bankrupt the patient or the system.
Yeah. Well, I don't know if Hippocrates knew that to bankrupt the system.
If you were to rewrite it today.
Yeah. So, and is it fair to say you have like state-of-the-art equipment at your fingertips?
Yes.
And
Yep.
yeah.
Yeah.
So, Go ahead.
And in radiation oncology, I mean, it's a very, state of the art is sometimes, if you got 3 radiation oncologists in the room from 3 different, major cancer centers, we might start, throwing punches over who's, state of the art is really state of the art, protons, or, do you have an MRI linear accelerator, or, would you have the fanciest kind of brachytherapy? And by the way, I can break down all those terminologies for you all at any time. But yeah, and then someone might say, like, oh, your protons don't matter here, but yes, in the military, we've never really been deprived of modern technology for budgetary reasons, especially in the genitourinary prostate realm.
Great. So why don't we talk about the kind of patients you see and what your particular practice offers them?
Absolutely.
So are most of the guys, within the military, the men there are required to have at least an annual physical, or how does that play out?
Yeah, while you're active duty, absolutely, or some sort of physical exam equivalent.
I mean, what I'm trying to wonder is like it's reliable, PSA tests and digital rectal exams are reliably offered to everyone that you see annually, at least?
I would say they're a lot more prolific in the system now. I will say, I mean, again, with the military healthcare providers trying to be evidence-based, you may have seen when there was a time when they started to advise against screening PSA, the NSPTF, while the American Urological Society still carried it on. And so I saw family medicine doctors being like, well, the USPTF moved away from it. And they're, again, and they're very, empiric and academic. So except for that time period, though, absolutely. And they were tracking it very well. And finally, just one of the other points is, people hit hard during a retirement physical. People try to it's kind of a catch-all time period for percent disability. So people will get, if no other time, they'll get it at their retirement physical.
So this sort of leads to the question, is it fair to say that within a military setting, you're more likely to see guys at early stage or, catch things early than in the
That certainly is a hypothesis, which, ties both in with, active duty military as well as, population, equality of outcomes.
So what do you, a patient comes into your office, you order them to sit down, you order them to pay attention. No, I'm joking, obviously, but the idea is that the conversation is, doctor, I'm diagnosed with prostate cancer. What should I do? What's that conversation for you and the soldier like?
Yeah, absolutely. So, and it's one of those things you see, it goes all the way from, an active duty, enlisted, typically at the higher end of enlisted, because you don't see too many people, in their 20s with, or 30s for that matter, with prostate cancer, all the way up to, multi-star generals coming in. And, one of the things is, typically it's not, we've always adhered by a multidisciplinary format, incorporating with the urologists, they're the ones who essentially diagnose it. And, discussing with them really, the number one thing that we always did was, just try to frame out the risk factors going into the prostate cancer diagnosis. So looking at PSA trajectory, as well as the breakdown of their biopsy and the Gleason scores. Now, I'm just going to go straight into it. We're using additional items quite regularly, and it is, tying right into what you said. We do have a little bit more of an access. We've been getting multi-parametric MRIs on pretty much all men, even with lower risk disease, for at least 5 years. The quality has been increasing each year. That's a whole separate discussion. And then we're doing a genetic analysis side on someone newly diagnosed is something that we individualize. And then finally, advanced imaging is something, based on risk stratification, based on the Gleason and PSA and other factors, as well as, again, a personalized situation.
And you're reading all the scans yourself, or just like in civilian life, there's a radiologist somewhere else?
They're absolutely a radiologist. Yes.
Yeah. So you sit down, you talk with the patient, and I mean, have you grown to have a preferred protocol for each stage of prostate cancer, or it's a real different thing?
No, I mean that's a fantastic question. So that I absolutely, so then we'll first thing we'll discuss the patient with, in a multidisciplinary tumor board where, you get at least, about 3 rad oncs, 2 or 3 urologists, and we discuss it. And the urologists are typically oncologically trained urologists as well. So they do even an additional fellowship. So, and there can be different opinions for a similar patient, just simply based on, again, based on how one has formed their own practice. Additionally, I will say now from the radiation oncology side, and truthfully, so the NCCN, the National Comprehensive Cancer Network guidelines in prostate have actually become a lot more specific over the last 2 to 3 years. It's a very interesting kind of migration. When I first started residency, some years ago, the NCCN for prostate was much more nebulous. They didn't specifically spell out things like life expectancy duration. They didn't specifically spell out, in the various risk group substratifications. But now, honestly, there's a lot of personalization, but I actually have to sometimes check my own ways of personalizing in lieu of now the NCCN is a lot more specific.
And so, I mean, are patients aware of that you're following guidelines versus having a shared decision kind of deal going on?
Yeah, and the NCCN does allow for shared decision at each of the stratifications. The truth is that, there was very much a time period where I would say in practice, and during my residency, for example, I trained at the NIH, NCI, National Cancer Institute, and that the NCI is so if you're doing trials, that is one of the most stringent parameters for treating prostate cancer, right? You are not going to deviate from anything. But even inside of that environment, there was so much wiggle room inside of, various prostate cancer risk stratifications that we would need to very much personalize treatments. Honestly, these days I am bringing it up more with patients that, and here's the NCCN. And really, the NCCN fits the way I would have been approaching them anyway. So not too much, strife between the two. Although I will say on threshold cases, it's challenging because you certainly do feel like the NCCN would want you to treat in a certain way. And that's still an area where you will see individualization, personalization.
Yeah. And within the military, since people are, where they are, and if they're not local to you a year or two out, you could certainly locate them, I imagine. Your patients who you've treated, you're actually perhaps more profoundly aware of outcomes relative to the initial treatments that you offered than a civilian doctor might be. Is that fair to say?
I think that is fair in many situations. But yes, longitudinal data is probably, we are a unique database. I'm thinking through this while I talk because, there've been a couple of different research projects I've participated in, and that's generally been the impetus for military-based, data reporting is exactly that point. So sometimes we have more robust outcomes. Although certainly now in the era of big data, any of these major cancer centers wants to generate mineable databases for their own research publications. So we're probably no longer quite the, unique snowflake that we used to be, but there's certainly been a time. And for example, like the Center for Prostate Disease Research, that's kind of specific to military and also with some VA, they have one of the most robust, if not the most robust prostate data set in the entire world. So certainly, it certainly is a fair point.
And for our audience, I mean, we will get to radiation therapy in a moment, but I mean, this is a sort of a rare opportunity. The idea of clinical trial accrual, it's super hard in civilian life. Are you allowed to even offer clinical trials? And I'm thinking this, soldiers, even retired soldiers, they may feel an obligation to volunteer, perhaps as a career, like perhaps a colonel or a brigadier general looking for another star or something, may feel like I'm going to, if I do this trial, it's another, nice thing on my record. I mean, is there a thing like that going on?
No, absolutely not. And one of the things, and I'll tell you, we have pretty robust institutional review boards because of things like that. So some people would argue, I don't know if this shows up on the specific ethics in research, but I actually think there is a little caveat for military. But yeah, just because there are historically incidents of military being put into like some sort of vaccine trial or something, going back like 30s, 40s, 50s, that they are considered a vulnerable population. So you need to be cognizant of that, and you can't give them some sort of you can't give them protocols that you would not offer to the civilian population. And almost even more so in the VA even.
Yeah, good to know. So let's spend like 15 or 20 minutes hearing how you tell a patient what the options for radiation therapy are.
Yeah, absolutely. I mean, so someone walks into my office, the most important thing is to kind of figure out whether they have very low risk disease, low risk disease, favorable intermediate, unfavorable intermediate, high or very high risk prostate cancer. And those are all based off of the PSA, the Gleason score of the prostate biopsy, as well as the number of cores involved. For the very lowest cancers, you're looking to see what the PSA density even is, which essentially means like, could this just be your normal PSA because you have a larger prostate, and then a little bit of low risk prostate cancer. But then going into the higher risk cancers, then additionally looking, the clinical stage, which is now being almost surpassed by MRI. So the clinical stage being, what someone feels on digital rectal exam. Just within the last, month or two, I have a number of patients who both myself and the urologist feel is a clinical T1C or nothing. And, but on MRI, there's radiographic evidence that there's a little bulge that could be consistent with extracapsular extension. So, then we have to reconcile is, do we upstage that person potentially to a high risk or not? Looking for seminal vesicle involvement as well on the MRI. And then finally looking at systemic staging to rule out metastatic disease or find if there is a little bit or a lot of bit of metastatic disease. And that includes either a bone scan, a CT, or even advanced scans. I'll tell you in the military, just to, again, cut to the chase on one, if we have a secret sauce, what it's made out of, we're using the Oxman scan, fluciclovine a lot, and we've been, generally very happy with it.
Yeah. And so all these scans are offered before you have like a final, this is what we're going to do kind of thing?
Yes, absolutely.
Yeah.
And then for more advanced cancers, we do bring up, options of, even things like second opinions or what have you, if the patient is so inclined.
Yeah. And do your patients generally understand the scans and are interested, or it just floats over them and they want to hear what they're going to do next?
I think they understand them pretty well. I generally tell them for the MRI of the prostate, it's certainly an important scan. It probably does, it means more to me than it does potentially to them, because then I have to interpret it. And then additionally, I think for the, but then for the systemic scans, they definitely care about it, because, they don't want to be, metastatic or incurable. And we have a lot more discussion. Truthfully, I find like the fluciclovine oxymin scan is a very important scan for, shared patient physician decision-making, no matter what it shows. It's interesting because when I was at the NCI, we also had a whole bunch of prostate cancer patients that would show up just for specific scans. So they're not as interested in the scans as that group was, where they would go to one hospital just to get a specific scan. But yeah, they are. Yeah. I do think, though, that you bring up a point, though, is that, in these, 20 minutes, we've just outlined, a multitude of points. I do think in prostate cancer, you're getting, over the last 10 years, we've moved closer to a time period where the information is almost overwhelming. I certainly, if I'm even starting to feel it a little bit as a physician, what is it like to the patients? I do feel like having a complete 360 grasp of the field now has become at least more challenging, because there have been a lot of developments. Even before I sat down to speak to you, I wanted to review, just our society's latest guidelines, just to make sure I'm not saying something that's completely out of left field.
Yeah, because they're updated so quickly and so frequently. Yeah. It used to be biannual or whatever it was, and now it's like bi-monthly almost.
Well, exactly. In the prostate, they've actually been pushing them. So you can pull up another NCCN cancer site, and you might be looking at something, maybe like 2 years old or something. But the prostate, they've been pushing them, and the update list is long.
Yeah. So is it possible that the shared decisioning kind of thing, that's sort of, half marketed, half bantered, and mostly useful? Can that actually become a point of stress for the patient that actually may be unfair? Yeah.
Yeah, absolutely. And so, and I think, just to speak frankly, and because I have no problem telling my patients this, and same to, the group out there. There is a fine line these days between, paternalism and almost like neglect, or a role reversal, or what have you. And, medicine, we've been told for a long time, is to be careful of paternalism, right? Because that just, that can lead to us, essentially, people cannot be happy with it. I will tell you, at the end of the day, for any patient with prostate cancer, is the right treatment decision is the one they decide on, is if they're given good information, and they're not being sold some sort of therapy that's not adherent to the NCCN guidelines, if they're not having to pay all cash for some sort of weird herbal remedy, as long as that's not the case, the treatment they make is the right decision. And as such, but again, I think, I've seen plenty of cases, including, during residency, when you follow other doctors, if you're being too, well, it's your choice. It can cause a lot of analysis paralysis.
Yeah. And you make a brilliant point that we stress in our support groups, and probably going on now 15 years, when one of our other group leaders came up with this, and we all gathered around for a month or two back and forth discussing the idea that your gut is as much of a metric as anything else, the patient's gut. If you're going to make a choice, since outcomes are, you can't really say one, except for a rare case where it's clearly, one treatment is appropriate for a particular presentation. But in general, outcomes are comparable. It's a crapshoot what's going to happen, both in terms of morbidity, side effects and stuff. It's an outcome, a crapshoot whether you're going to have recurrence or you're going to be fine till you're 120 and die from prostate cancer then. The patient needs to feel comfortable with whatever choice they make. And once they make the choice, there's a certain power and solace that comes from that process, and from just owning what you're about to do, and that in itself is a quality of treatment that is rarely discussed in a doctor-patient setting. You know, like we would love doctors to say to patients, you know, whatever choice you make, as you just did, as you just said, whatever choice you make will be the right choice. Because, you know, 5 years, 10 years down the road, that's when you're going to know whether it was a good choice or not, or a successful choice. But it'll always be a good choice because you did the best you could with what was on your plate on this day in 2020 or 21, you know? And
I agree.
yeah.
And I also think that there have been even a couple data points that have come up even in the last 3 to 4 years. One of which being, now we have better ways potentially of, if someone does have a limited amount of disease recurrence, we have better ways of salvaging that now. And additionally, some people used to say, and some people still may say this, and I'm not going to say they're wrong, but for higher risk prostate cancers, that either surgery or radiation therapy is clearly the better option. If you do one or the other, then you've undermined yourself. One of the things that did come out though is that salvage radiation, we used to think that maybe it wasn't as effective as if we would have gotten a shot up front. But now we actually have more modern data and modern patients when combining salvage with hormone therapy, and really the survival curves look quite good. So again, I mean, that just reinforces that point. Is I think there have been actually some developments and some more data that have come out, which I think, if anything, it just shows that an ongoing quality therapeutic relationship with your physician post any sort of treatment, following up, is probably going to be a very important factor in ultimately achieving a satisfactory outcome, both in terms of disease control and toxicity management and mitigation.
Yeah. And do you think there may be yet another advantage to a military setting in that patients can feel confident the doctor's not, whatever nonsense there is about the doctors trying to make a lot of money off of me or whatever, there are patients that have that in the back of their head, and that sort of disperses in a military setting, because you're making whatever you make, and
exactly. Yeah. I don't get paid extra to take on a additional patient.
Yeah. And you don't get like an extra braid on your lapel, on your whatever you call shoulder thing or whatever.
No.
Yeah.
Sometimes you can get a special parking spot, but
well, that is worth
you don't want to know what people will do for parking spots at certain hospitals, but at BAMC it's we have plenty of parking.
Yeah. So the idea that patients and doctors are I mean, you're wearing the same clothing, more or less. You shop at the same stores, you eat in the same place, more or less. I mean, you have your own homes, but on a base. But I mean, it's sort of a more cohesive, more even keel, more democratic place in an odd way than perhaps the civilian settings where patients are seeking health care and where patients have to shop around. Do your patients have a choice in doctors and hospitals?
I mean, yeah, I mean, ultimately, yes. I mean, and first point, just to address what you're saying, I mean, we don't have data to show it. I mean, it would be challenging to collect that. But, when we've looked at other data sets, we almost have to look at, is like therapeutic adherence, is that almost a confounding factor in studies? Because as you said, I mean, I do think there's an inherent increase in trust that does come, with, uniform to uniform or retiree to uniform. I mean, God, it feels, I'll tell you, I have a lot of end of life patients who, they don't want to be anywhere else. They want to be here, if they're dying of cancer, because they know they'll be treated right. And that goes into, do people have a choice? And they do. There are, I mean, honestly, it's pretty easy to get second opinions, I would say, in this system. There are some regional medical rules that are always in flux if someone wants to get care somewhere else. But I'd say this, I mean, I wouldn't say that, there have been many issues with people, not getting to go where they want.
Let's talk about return to what we
Yeah.
put as a headline, which I guess I'm going to have to change a bit, but
Those are the
which
best
is
ones.
fine. Yeah, I mean the idea of, I mean, different kinds of nuclear medicine, different kinds of radiation
Yeah.
therapy. In the last 10 years or so, fractionation has been reduced from 40 to 5, 40
Yeah.
sessions over 8 weeks in general, to now you could do 5 by pumping in more rads
Yeah.
and gray units. What's that been like I mean, what are your thoughts on that?
Yeah. Yeah. I mean, one of the experts in our field, Dr. Wen from Mass Gen, I believe. Have to edit that if I'm wrong. But he just brought up that actually now doing the 8 weeks is like his least favorite approach. And again, that's one of our field thought leaders, and as have many others. So for me, I mean, prostate SBRT was something that, I'm familiar with. I've done it. It requires, a slightly, at least slightly higher kind of technical knowledge. And you have to have a slightly higher, technical system of being able to ensure high doses are delivered accurately. So it's a little bit more stressful. The thing is all these ones in the middle have shown that they're very good, fractionation between 20 and 28 fractions. They're one of the big draws of them is they're actually kind of easy to implement, especially if you have, so in radiation oncology, there's a thing called image guidance. So image guided radiation therapy, that's a very broad term, but it includes things from just like doing a scan every day to make sure you're on target, to putting fiducials in to make sure you're on target. I think one of the biggest ways we improved our image guidance is actually now, everyone I treat has an MRI, and I think most rad oncs out there now are, using an MRI, and that just helps you, again, be more on target. So if you're delivering bigger doses per fraction, you probably want to be as on target as possible. I'm here with some of my coworkers here who have really spent time trying to narrow down, how tight they can treat on the prostate. They've really, critically looked at it, and they've even, some of them have even been able to take it a millimeter or two, tighter than I am. And, and my response has always been hats off, bravo.
Yeah. And this might be a good point to talk about what you imagine, because of you have the scans in your head,
Yeah.
that patients don't have a clue about.
Yeah.
And that's like, the prostate moves, it's shaped differently, it's different sizes, and you've got a target, and in a 3-dimensional and 4th dimensional, if you include time.
Yep.
Even if it's a second or two, there's movement within that. Well, why don't you describe? Go ahead.
Clearly, a lot about it, because that's a good, good descriptor. So if my fist is a prostate, except it's typically smaller than this would be a large prostate. But, you're going to treat the entire prostate. You're also going to add on a certain number of millimeters based on, there's actually a mathematical formula you can run to get a estimation of how much you should put on it. But basically it's based on, number one, what are your uncertainties in your target delineation? Okay, that's the first and most important point. So that's why I brought up is, when I look at the prostate on a CT, it looks a lot fuzzier than if you look at it on a MRI. The MRI is very sharp most of the time. A high quality one is, at least. If my MRI is bad, you may need to add a little bit more margin. Secondly, the rectum, because it's right behind the prostate, that can have day-to-day variability. With radiation therapy, there's 2 concepts. There's when we line the patient up on the table to make sure, again, we're locked on, beams are going to come right in. But then what about in the 1 to 5 minutes it takes to deliver the radiation? What if suddenly a gas bubble passes in and moves the prostate? In traditional radiation, it may not have mattered, but now with, these more advanced techniques, it certainly matters, especially like you said, if you go down to 5 treatments, and you've moved by 5 millimeters. I mean, that could be the difference between a successful treatment course and a non-successful treatment course. So there are different ways. At our institution, we've looked at a couple different ways to try to mitigate that. There's a technology called Calypso beacons, which allow for you to track intra-fraction motion. So during the treatment, there's techniques that you can use to line up also where you're scanning while your external beam is rotating around the patient. Finally, there are other techniques that may be coming out in the near future, more and more mainstream. I mean, all the way up to thinking about, hey, are we going to have an MRI-based linear accelerator in this clinic in the future?
Yeah, I've seen photos of there's one at Sloan Kettering here in New York, it looks kind of goofy. I mean, it's literally half MRI, so half pipe, half linear accelerator, and the patient's like backed up and put in and backed up and put in.
Oh, so yeah, and so so what you're talking about is a on rails solution, which is fantastic for some situations. The only problem is you can't dynamically MRI them. So now there's actually a couple different technologies that come out where you're actually acquiring an MRI while you're delivering the radiation therapy. Yeah. So the on rails is fantastic, and especially for brachytherapy and gynecologic cancers. This is actually even one step beyond that.
Cool. And is that like 90% of the game is targeting? How would you do it?
I mean, that's a great question. I would say, and this is just in my opinion, I mean, I would say for delivering sophisticated radiation treatments, again, this is something in the military that we regularly, we have to sit down and say, okay, RadOnc in the military, we're a good size. We have, an excellent batch of physicians. We are not as large as one of these major cancer centers where you have, essentially, a slew of physicists, and you have dozens of physicians. So how do we have the most effective radiation oncology program possible that's the safest, while also not trying to overstep our bounds and do something that maybe is too experimental and outside of that? So the things that we've the most important things that we've relied on is so our physics department are really the ones who help us to ensure that our machines are precise, that the treatments we deliver are kind of within normal parameters. And that all does go into the imaging side of things, yes. The second thing is I would say is then just patient selection. So ideally, having a good workup on a patient is critical. Right now, I tell actually a lot of my patients, an MRI of the prostate is not an MRI of the prostate, at a different institution. Like, there are major differences in prostate MRI quality, and it has to do with the strength of the magnet, but it also has to do with a lot of other parameters. So, that definitely helps.
Does the military sort of even that out, and that an MRI at one base is equal to an MRI at another, or not?
Yeah, our MRI technology, we get pretty good MRIs because of, the combat mission, and the surgeons like the best MRIs.
Yeah. Are you able to do MRIs in the field, like in Afghanistan or the Philippines or something?
So not until you get to one of the major centers. They generally have used CTs. Not exactly my area of expertise, because while I fall under the Department of Radiology, I'm not a radiologist, but they have very mobile CT solutions.
Yeah. So telemedicine from a conflict zone or a battlefield to someplace in America is not yet here?
Oh, no. Yeah, no, it's here.
It's here.
We have full telemedicine from the battlefields. It's just
not. I misspoke. Doing a remote image, having it read stateside, so to speak.
Oh yeah, and a lot of the times they'll deploy radiologists downfield, for things like, so all the way, if there's like a mobile CT, yeah, so there are CTs that are deployed very far forward.
Great. I could feel like a bunch of 1,000 virtual guys behind me asking, if the opportunity for screwing up targeting is possible. And that screwed up targeting is going to impact my quality of life. And I'm retired and I don't mind going in for 40 days, for 8 weeks. Is the old-fashioned IMRT going to give me a better long-term quality of life outcome than a 5-day hyperfractionated stereotactic solution?
I mean, that's a good question. So I think probably the best, so this is where you get into information opacity, okay? Because if you go into the car dealership, you probably at least have a consumer reports or something on the car. You know what you're kind of buying if you're getting leather seats and what have you. When you go into the physician's office, you have hospital affiliation, residency training, number of years in practice, and potentially, other referrals. You have to rely on that a lot. Because it's, it's very, at the end of the day, when a plan's being put together, I mean, it's very much, it's in the oncologist's hands. I think that, I do not think that though pursuing just like an IMRT approach, I don't think there's evidence now to say that. I think if you're less comfortable with some of the sophisticated modalities, that certainly, but again, I mean, 28 treatments is still, I don't think there's any evidence to suggest that would put you at a higher risk of long-term toxicity.
Yeah.
But certainly when you're getting down to the lower numbers, that's why you'll see, some places will be like, CyberKnife prostate, and that sort of thing. And they just do so much of it that they get very comfortable with it. Same thing kind of goes with brachytherapy. You certainly want, you want someone who does more cases than less cases. And those are either the implantable seeds or the tubes with the radioactive sources. So, I think trying to find a quality doctor who's, does this, I think that's important. There's a couple other cheats out there. The SpaceOAR hydrogel is something that could turn a really complicated treatment with a good SpaceOAR placement. You got a lot more margin on the rectum. And that's, and I can explain that more.
Yeah,
if you
can you do like a 90-second or less thing on that?
Yeah, so the SpaceOAR is so it's a gel.
You could do a fist and an arm thing.
Yeah, okay. So if you have a prostate and rectum right here, so you inject in between the prostate and the rectum a dissolvable gel that essentially displaces the prostate from the rectum, and it's like a two-phase epoxy that comes together. So once you start injecting that, you're going, and as long as it's a good quality, you can, if you were going in the past, you almost always radiate a little bit of the front of the rectum, but a good one on that really takes away the high dose from the rectum. So for certain patients, it's a great, it's a great procedure to have done.
Certain, go on.
Oh, it adds a procedure, and there is a small risk of complications from it as well.
But for certain patients, it's not appropriate. Those with, I guess, higher grade disease and
such. Extracapsular extension, you really can't do it. And oncologically, it probably doesn't make sense. So if you have cancer coming outside of the prostate, if there's any chance you're going to push those cells in a direction, you don't want it.
Yeah.
We don't have data to show it's safe yet, so we'd be very cautious.
Let's talk about three more things, and that because we're sort of running out of time. But three more things there. MRIs. What if you were to draw up a one sheet of patients should ask for these characteristics of an MRI to ensure the highest quality MRI? What should a patient ask for?
Okay, so the first, I think the most simple thing is to make sure the institution you're having it done at really has a genitourinary prostate MRI program, and that they're comfortable doing it. Ideally, the urologists are also involved with it because, again, speaking to both, early and later stage patients, you can use the MRI as to guide even additional biopsies potentially. You might have your initial prostate cancer diagnosis. But sometimes the MRI can show something. So there's a thing called a median lobe, which is up in the bladder. Well, if there's something up in the median lobe, that doesn't always get biopsied. Additionally, really the site we're concerned about is the anterior prostate. And that's a site that can be undersampled. And if there was a really highly concerning area up there, that maybe should be additionally biopsied, especially if the results of your biopsy weren't concordant with maybe a higher PSA value. The MRI isn't just assessing anatomy too. There's a way by using the timing of when the contrast goes into the prostate is called a dynamic contrast enhancement. And that's from multiply acquiring slices of the prostate. That can actually show you how concerning maybe a nodule in the prostate is, and if it's concerning for a very high grade disease. So the dynamic contrast enhancement is something that people should probably think about, especially if they're a lower or intermediate risk patient who's worried about, occult or subtle high risk disease. And that's not really a technique that all places are super comfortable with. There used to be a time where the strength of the magnet was a big differentiator. From my current understanding, it's not so much anymore. And then finally, the other point of note is, doing an endorectal coil. That was something that a lot of places were doing to obtain the highest quality images. Now with higher magnet strengths, and I also think there's other parameters that go with it, the endorectal coil is more, some places probably use it or need it, but it's not always needed. So if you don't get an endorectal coil with your MRI, you're not getting a substandard scan.
Yeah, and few people would actually desire one of those.
Oh no! Oh my gosh! Yeah, nobody wants that. But for a while, and at some places they are super important, or your MRI looks like garbage.
Yeah. Well, that would be a place, unless you have no other choice, a place not to be treated, not to get a scan.
Yeah. Also, I will say if a place believes in their technology so much that they're putting endorectal coils in patients, I actually have some faith in that, because it's not something that you just sign up for unless you truly have a quality system.
Yeah. So next thing, military service. Does that, so people have talked about Agent Orange and things like that. Are there aspects of military service that may lead to higher incidence of prostate cancer?
The truth of the matter, on that question, I have to defer just a little bit. I would probably say just to be frank about it, I would probably say I would defer you to, the VA, paradigm. Personally, but I feel pretty comfortable in saying this. In my time in the military, I've never really seen some strange, tip of the iceberg, there's an increased risk of this cancer in my military population. And believe me, it's something I'm, exquisitely aware of, and by the way, if I were to discover something like that, I'd make my career by publishing on it and potentially saving people as well. So, I've never really seen anything like that. The truth is, and one of the strengths of, for my career in the military and outside some days, we treat all kinds of cancers in relatively population and demographic respective ratios. We got a few more lung cases out there because, they used to issue cigarettes, right?
Yeah. That and chocolate, so I guess a bit of obesity or hypertension,
yeah.
Glycemia or whatever. And finally, let's talk within this video. Let's talk about racial disparities. In civilian life, prostate cancer kills Black men more or less at 2.4 times the rate as it kills white men. Black men present with higher stage, higher grade disease initially than white men typically. But that's not really the case across the board, across all 5 services in the military, is it? Or
yeah, no, you're exactly right. And and this was something, when we were first, chatting about, setting this up, that was an area that I'd done some research on, for the same reasons as, in discussion earlier, that, we do have more of a cohort that we can follow in the military. So, I mean, when I was curious about looking into this, it was all actually based on when I would sit down, you know, face to face with a Black African-American gentleman. Because I was very aware of those numbers too, is one of the things that would come up is because we have a spectrum of treatments. Sometimes one would wonder, myself included, is should I intensify treatment for this person sitting in front of me to try to get them the most effective treatment possible? But that could also lead to overtreatment. So one of the things that you could look at is, you know, actually, like 20 years ago, the VA did publish something, and it was pretty indicative that there were not the same discrepancies between Black and all others in terms of prostate cancer outcomes. And I mean, and that is reassuring. The thing being is, you know, that was also with, you know, more older database techniques. And the thing about prostate cancer too, is when you look at data from 20 years ago, they actually had different ways of, you know, looking at risk stratification. The Gleason system still pretty much existed as it was, although you'd see things like Gleason 5s and Gleason 4s, which we really don't even bring up anymore. But also PSA testing wasn't the labs just weren't as sensitive yet. And if you go back much farther than that, then what you felt on DRE was of all, you know, of the highest priority. So, you know, here we are now. So we did, you know, look at the modern military, you know, database sets, and it showed, again, a stage for stage, you know, preservation of outcomes, at least on, you know, some degree of analysis. Others have looked at it now even in more detail. It's hard to tell exactly why that is, you know. Now, outside of, you know, the realm of data, you know, I mean, one of my, I think we hypothesize there are a couple parameters, one of which is, you know, more availability of screening, higher adherence to screening, therapeutic ratio with the physician. I mean, I think just to be frank with you, I think that, like, you know, if there's a racial difference between a civilian and a civilian, sometimes maybe that can't perfectly be overcome. But I at least, I mean, you know, again, speaking as a white doctor, but I've always felt that, like, the shared uniform has become very far in terms of enabling quality therapeutic relationships to be built, you know, with my patient population. And I do think that, you know, endears trust. And that may have a lot to do with it as well.
Yeah. So thank you very much for this extraordinary conversation. Very glad to have you as part of our conference, and welcome to the conference.
Thank you so much, Darryl.
Okay. And thank you for your service as well. I mean, you could be doing, you know, you could have a heated swimming pool in civilian life, and as opposed to whatever you've got on your base. So, but is the swimming pool heated on the base there?
Yeah, but you don't need it in San Antonio.
Ah, okay. All right. Thank you.
No problem. Take care, Darryl. Bye.